everyone, and welcome to our first Arkansas CQ and ADHD monthly practice call. Our agenda will be a quick roll call, report on PSAs, a bit of data review, some Me Health questions, clinical questions, reminders and announcements, and if we have time, presentation on reliable systems, although if we run out of time, we might switch that to the PCMH webinar, which is immediately following this webinar. So for roll call, I can actually see, and it looks like everyone can see on my participants list, that we have Mercy Pediatrics and Sparks and Central Arkansas Pediatric Partners, and I can see APC, and of course Dr. Kuo is here for ACH. So I'm actually just wondering if anyone is on from River City Pediatrics?
Yes, we're here.
Wonderful. That's great. Thank you. And quick housekeeping, please mute your phones if you're not speaking, and please don't put your phones on hold because we'll hear your hold music. And please feel free to ask questions and make comments at any time or use the chat box. These slides will be emailed to you right after the webinar, and a recording will be made available for those who were unable to attend, and you can find that on our ARAAP website, and I can send you the link to that as well. So, Dr. Kuo, if you'd like to present, I can switch the slides for you.
Chris, I think if you retain the control, I think that would be fine. So everyone, good afternoon. I hope everyone is doing well with the rain that's, I haven't looked outside in a few minutes. I realize it's rain. It looks like it's raining outside. So I wanted to take some time over the next 45 minutes. What we'll do is first go over some of the PDSA cycles and do a check-in with how folks are doing, and just get an update, and also just some discussion about any challenges or facilitators that we've seen. The next part is that we'll talk about some of the data and data updates, and we've got Ed Wise on the phone from the National Academy. The third is that we want to reserve some time with every webinar to reserve time for Dr. Jensen as our resource to talk about ADHD management questions. So the first slide here reviews very briefly the model for improvement. The model for improvement, as we've discussed, is just a little powerful conceptual tool that talks about how to make a change and get you from here to there. So anytime that you want to change something, you really do you have to ask yourself three different questions. The first is that you have to ask yourself, what are we trying to accomplish? The second is, how will we know that a change is an improvement? So you have to be able to measure and determine that you have actually moved the needle from here to there. And the third question, which is your idea, is what change can we make that will result in an improvement? And that's where plan, do, study, act cycles come in. Next slide, Kristen. So what we have asked practices to do is that between learning sessions, we will have a set of goals and that we would like practices to work on. From the end of the learning session, the first learning session, we had set a couple of goals. One of them was for practices to meet and work out the workflows for practices, and we didn't ask folks to come in and share some of their results, but I do think that in future calls that we will be asking folks to share some of the results so we can have a good discussion about what we're finding. And the second is to start going through the Me Health portal, and in addition to making sure that folks are signed up, that you're able to get to a point where you can start enrolling kids onto the Me Health portal. So we may find that one of the ground rules that I will put with any discussion is that there is no wrong answer, no wrong actions. There is everything that we talk about is a learning opportunity, whether we construe it as you met your goals or you didn't meet the goals that you set out. And if you didn't meet the goals you set out, as I said, you always look at it as a learning opportunity. So under each practice on the left-hand side, you will see that the question that I'll ask going forward is, what are the goals for the time of this call? The do is going to be, what actions have we taken since learning session 1? And so I'll ask for some updates from folks about kind of what things have gone on. The study, which we didn't really ask folks to really do this time, but we'll ask going into the future, is what data did we bring to this call and what does it show? And then the action is, what are our goals between now and the next month's call? Okay. Kristen, next slide. Okay. So what I'd like to do is just generate some discussion for the next 5 to 10 minutes or so about plans that you had since the last learning session and your experiences. And I want to just open it up at this point. If there's not a whole lot of discussion, I may start calling on folks. But my question is, how are things going? We've asked folks to do workflow analysis, and we asked folks to look at enrollment, to start enrolling. How are things going?
Hello, this is Joy Hill. Can you hear me?
Yes.
Okay. I think we've had some variable success. We're across 3 clinics, so that's been a little difficult. We got the workflow in, and I think Dr. Youngblood submitted it, but it was a little confusing because he was lead physician and he's not here today. But so at my site, my nurse was putting in, we were starting to enroll patients, my nurse and I, and we got about 5 or 6 enrolled, but they don't show up under my name or her name as our patients. They only show up under all the patients. So if they do turn in forms, I don't get notified.
Okay.
And so we've run into a little bit of a glitch there.
Okay. Kristen, do we have MeHealth troubleshooting on the phone today?
Yes, we have a section for that. And actually, I think for this section, we were wanting people to just go over how their first PDA went, what their plan was, and what they did, what's on the screen, asking questions about their PDSA.
Yeah. Okay. So assuming that like a PDSA would be to look at your workflow, what are the things that, are you able to share things that you've learned from your first workflow analysis? Joy, are you still there?
Yeah, well,
okay.
our initial workflow was just to try and get all the participating and supporting docs signed up for MeHealth. I'm not sure at the other clinic. Meredith might know better whether they were able to finish getting Dr. Dyer and Dr. J. Morrell enrolled on that and how that was going. And then at my clinic, we were able to get everybody signed up and start enrolling, but we did have that problem with not being able to tell whose patients were whose.
Okay. So really like a PDSA cycle, you said there was a PDSA cycle that was submitted?
Dr. Youngblood had started filling one out, and I thought he had submitted that with the workflow, but I don't know since he's not here today. He sent me an email saying what the PDSA was and what the workflow was that he had sent to Kristen. So I tried to send that back to you guys, but I don't know if it got completed.
Okay. We'll follow up on that. Kristen, are you able to follow up on that?
Sure. I'll definitely follow up.
Okay, great. Joy, thanks so much. Other folks share about your workflow analysis and your PDSA cycles, kind of your experience so far?
Well, Dr. Scher is here too. We've been implementing the workflow that apparently you don't have a copy of. And our PDSAs we've been doing there at Highway 102 as well, making sure Dr. Dyer does have an account with MeHealth and is working through the training. Dr. Demerel, last she had checked, still have yet to receive the activation email from MeHealth.
Okay. So it sounds like we still have some of the operation issues we need to work out to get folks, to get MeHealth working.
Right.
Okay. Now that's good to know. I think that's what we need to follow up. We'll follow up on that.
And then I'm pretty sure that I faxed our QI consent form to you guys, but I guess you guys didn't get it as well. That was.
No, we have your MOC form.
Okay. Okay. Great.
Okay.
We were looking for the PDSA, the copy of the PDSA that you put on the PDSA worksheet, but we do have the other parts of your homework.
Gotcha. Okay.
Okay. You need my MOC form too, or was it just one for the clinic?
You know, Allie is on here. I believe we need yours, but she can probably clarify that.
Since you guys, hi everybody, this is Allie. You guys, everyone speaking is from Mercy Clinics, correct?
Correct.
So we decided that since you guys all follow the same workflow, we just need one homework assignment from your entire team. So
right.
The one MOC form is fine, one PDSA worksheet is fine, and then one assessment and treatment flow is fine. So I do have your treatment flow, but it didn't include the assessment flow in there, so I just need that one for homework.
Okay.
And what about the order for the booklet? Were we doing one of those for all the clinics, or we were doing that separate?
I have all of your guys' orders separately. I had sent one a while ago, and the other two went out earlier this week, so you should be getting them at all the clinics soon. But I think they actually, the form had me sending it to just one, so you guys can distribute them across. But you guys got 3 orders of booklets since you have 3 sites.
We have the booklets at the 102 location, so I'm at Lowell today. So.
Oh, okay. Okay, so I need to get some from you, James?
There are definitely some at the 102 locations, but I believe she's, like she just said, she's sending them to each location.
They're all going to one location.
Okay, they're all going to go.
The same address. Yeah, so I think you should be getting another order that's enough for 2 more clinics at that same location. That was the address I had.
Okay, perfect.
Folks, in the interest of time and making sure that we have some time for Ed Wise and Dr. Jensen, what I'm going to what we'll do as a chapter is we're going to follow up with all of the practices to make sure that I think that we're still at a point where we need to figure out some of the operations. So one is that we'll make sure that that the MeHealth enrollment is taken care of, and 2 is that that we've gotten the communication down so we can get your PDSA cycles worksheets reviewed, and I'll be taking a look at them, and we'll either follow up with you personally, or we'll also ask some folks to talk about their cycles on the next call. If there's no other questions, immediate questions, what I suggest we do is I'd like to turn the time over to Ed, and we'll follow up with folks about the PDSA cycles and other administrative needs separately. So thanks for your feedback to this point. And Ed, are you there?
Might be on mute.
Okay.
Hold on, let's see. You on mute, Ed?
It says he's muted on the interface. I don't know if that's a self-mute or if Kristen, if you're able to unmute him.
I'm trying to unmute him. Oh, wait, yeah, it's not unmuting him on my side, so it might be a self-mute. Allie, is Ed there with you guys?
He actually works from home on Tuesdays, so usually I could just look over my cube wall and see what he was doing, but he's working from home. I just Skyped him, though, to see what if he's on the line or not. So he might be having connectivity issues because it looks like my Skype chat's not going through right now to him either.
Well, I can keep going and we can come back to Ed. Does that sound good?
Yeah, he just texted me and he said he lost internet, so that's the problem. So why don't we just come back?
Sure.
Okay. I'll tell you what, let's go ahead and move on to the clinical questions, one thing I'm thinking is I want to reserve some time if folks have specific clinical questions for Dr. Jensen. Another thing that we can do in the future is send your clinical questions ahead of time, and if we can discuss, so we have some topics to discuss. So my first question is, do folks have things that we want to raise with Dr. Jensen?
It sure is quiet.
Well, Dr. Jensen, do you have any questions for the group?
Well, yeah, one thing I may comment on, and maybe it'll stimulate a little discussion. You know, I did an ADHD collaborative, the very first one done by the Academy and NICHQ, the National Institute for Healthcare Improvement, and Children's Healthcare Quality, I guess it is, with Mark Woolreich, who was at Vanderbilt at the time, and now he's at Oklahoma. And one of the things that we noticed was that people were able to really begin using the rating scales, just as you're able to do now with the portal. Of course, you have all the automated benefits of the portal. But the thing we found was people often struggled, and we found it a challenge, to really help the docs and the prescribers adjust the medicine. And so, and what we've seen generally is people tend to use, you know, they'll look at the rating scales, but they won't use the rating scales just like you might use a hemoglobin A1C, really to look for a critical threshold of where you need to get the symptoms down to. On the Vanderbilt, about an average of scores of 1 on the first 18 items, and even on the ODD items as well. And so one thing I would just encourage you to do is, as you use the portal for your initial assessments and then to track as you follow up, keep a good eye on how much treatment response you want. And often we find that 25% is not really sufficient to really help a child get maximal outcomes. And so you really want to shoot for getting rid of any 2s and 3s, you know, always or very often, and get down to the sometimes level for most of the symptoms. So that's just a thought, and that may be a challenge sometimes if we're a little leery of the medications or we're worried about, you know, always balancing side effects. But let me just throw that out there as a really, really good practice. And what we know from the data is your kids will really have the best outcomes if you get them to that level.
Great, Peter. Thanks. Thanks for that nugget of information.
I have a question.
Go ahead.
I have a question. This is Dr. Ibrahim. I have a question about kiddos on stimulant medications who may develop motor or vocal tics. What is your, I guess, your treatment approach on, do you discontinue the stimulant? Do you just continue it or?
Yeah, great question. Well, first of all, we know that kids with ADHD, about 50% have tics. Sometimes you may not notice because they're subtle. And so what we've learned over, you know, now a couple decades, the relationship between the medicines and tics is kind of variable. So, for example, you might raise a medicine and the tics go away again. You may have it on a lower dose, but not on a higher dose. And so it really depends if the tic is really bothersome to the child or the parent. And so we don't, you know, the data indicate that stimulants don't cause tics. They kind of make them more apparent. And so if a child or a parent is bothered by the tic, you might play with the dose a bit. You may have to consider switching to another stimulant. So for example, you might find a child tics on, say, Focalin or something like that, but not on Concerta. even though it's the same molecule, because sometimes it's related to how fast the medicine is released in the bloodstream. So generally the strategy is, if it's not severe and not bothersome, you can ignore it. If it is bothersome to all concerned, you can play with the dose, switch to a different formulation of the same medication or molecule, like methylphenidate, or switch to the other stimulant you haven't tried. Now, sometimes, there have been lovely studies of kids with severe tics, Tourette's, and ADHD, and what those studies showed you is you got the very best outcomes by using both a stimulant and something like clonidine. And so clonidine is effective in addressing tic-related issues. Clonidine's more effective for the tics, and the stimulant's more effective for the ADHD. And the same, we don't have the same number of studies with 10X or Intuniv, but I suspect it would work the same way. So sometimes you have to add the alpha-2 agonist in to really fully control the tics that might be bothersome or worrisome.
Okay, one more question. Between generic and brand name stimulant, is there a difference? I mean, is there something that you would recommend, like you recommend the brand name versus generic?
Well, it's a great question. When someone develops a generic, they have to only demonstrate that it's got 75% of the bioavailability of the original patented drug. And so it's not uncommon for someone to say, golly, you know, I work great on this medicine, but I switched to this generic or maybe another form of the generic, and it doesn't seem to be working well. And I think we have to be attentive that that is possible, but costs also weigh in as well. And so, but is it possible that someone does better on a brand? Absolutely. Than on a generic. And so, you know, that's just one of the issues you have to struggle with when, say, someone's insurance company limits the use of, say, certain brands over generics.
Thank you.
Yeah.
Peter, thanks so much. Is Ed back on? I thought I heard someone call back in.
Yes, yeah, I'm back on.
Okay. Cool. Ed, I'm going to give you some time to discuss data and get us set up for the next call.
Sounds good. Thanks. So we're having some problems getting the right data from MeHealth for us to create these reports that I'm going to push out once a month. I feel confident that everything will be cleaned up and taken care of before the next round of reporting. So what I wanted to do is just, first of all, look at the reporting format, so what you'll be expecting next month to be receiving from me. And this is going to be, the first page is going to be all the data rolled up on the national level. So it's going to be data from every patient in every chapter that's a part of the project. So as you'll see, there's one run chart for each of the 7 measures, starting with number 1 up in the left-hand corner. That's the percent of patients with Vanderbilt assessments completed within 30 days of initiation. That's the assessment measure, and you can read the rest of them, but these will be the 7 measures that we discussed, or that were discussed on the learning session webinar. Down at the bottom on the right-hand corner, you'll see that this is going to be a count of the patients registered in MeHealth. So this will be the format that the reports will be, that you'll be receiving on a monthly basis from us. If you can go to the next slide, please. You'll also have the same thing, basically, but on the chapter level. You'll also be receiving one on the practice level that looks basically the same. So you can compare your chapter Arkansas to the other chapters that are participating in the project on each of the 7 measures. And then you'll also be able to look at the practice level data for the other practices in your chapter and be able to compare how you're doing with the other practices in your chapter. Next slide, please. So this data is accurate. We do have accurate counts of the number of patients being entered in MeHealth, so I thought that we could at least look at that. And this is just for December and January, so any patients entered in February are not going to be a part of this report at this point. That'll be a part of the March report. And as you can see, you guys are getting going with 26 patients being entered into MeHealth. Quite a few patients were entered by one practice in Georgia, so that's kind of inflating their overall number a little bit. Next slide. And this is a breakdown of those 26 patients entered by the practices in Arkansas. As you can see, it looks like Mercy Lowell has the most at 14, and then Bentonville 2, Arkansas Pediatric Clinic 6, and Pediatric Partners 4. So each month you'll be able to see how many patients are being entered for each practice, as well as those other measures that I showed on the previous report. Next slide. At this point, this is some other data that I know is accurate, and at this point, there's only one practice that really has the relevant data, but this is something that I think we'll want to keep an eye on moving forward. In the numerator column there, you see the number of patients who started a parent assessment. So a parent assessment was sent out for 2 patients, and those 2 had that completed. That is out of 3 patients that had the assessment sent out to them and activated their accounts. So far in Mercy, it looks like Mercy Lowell, 2/3 of the patients, a very small sample size, of course, but 2/3 of those patients have had their patient account activated, and 2 of those have completed the assessment. And then you can see, again, the breakdown of the number of patients registered in each practice. That way you can get an idea of the sample size for each practice. So one thing that stands out for Lowell is they did have the 3 patients where the parents activated their accounts, but that's out of 14 patients that have been added to MeHealth. Okay. And one last note is I would just like to reinforce that you check the data in your dashboard in MeHealth, especially while we have little visibility to the data at the chapter and national level. Please make sure you're checking your data regularly in the MeHealth dashboard. We have a
Ed, thanks for the information and the presentation. Folks have questions for Ed?
Hey, Dennis, this is Chris. Can you hear me?
Yeah.
So one of the things on MeHealth that we notice is that when we're getting Vanderbilt assessments back, that it doesn't give us any type of alert that they've been completed unless it's the assessment. So the follow-up forms, we're not being alerted to them showing up in MeHealth. Is there a setting that we can set that we get some sort of alert when a parent or teacher completes a Vanderbilt?
You know, I actually don't know that question. Ed, do you have the answer?
That is, yeah, I do. Unfortunately, there is not an alert for the follow-up. So you're exactly right. When the assessment is completed by parent and teacher, you will receive an email alert, and you get that little flag at the top of your login screen. But there is not an email sent for completed follow-up assessments. Now, I will say that every chapter someone has asked the same question or suggested that they have a flag for the follow-up emails. I'm going to talk to MeHealth this afternoon, and I'm going to see if that's something they would consider doing, or what is their rationale for not having the flag for follow-up emails.
Thanks, Ed. Other questions?
Yes, this is Dr. Abraham. I have one more question. When we started the program, I logged in as an administrator, and then later on I added myself as a physician. So on the physician list, or the practice, I guess, practice list, I'm listed twice. So if they enter patients on one of my names, sometimes it would show as I'm the primary care doctor, and some of the other, if they enter the patients on my name that is administrative, it will not go as if I'm the primary care doctor. So is it do I have to be listed twice, or can I remove the administrative one?
I'll work with MeHealth to remove the administrator one. Is someone else the administrator at this point at your practice?
No. Would it be like preferred that one of them would be the administrator?
Yeah, we're going to want to have one administrator for your practice. It doesn't necessarily have to be you. You want to give me a name, or would it be better if I follow up offline?
I can give you a name now.
Okay. Who would you like to be set as the administrator?
Ashley Morton.
Okay. Okay, I'll have her made as the administrator. Make sure that any data that's related to your administrator account is tied to your physician account, and then get rid of your administrator account.
All right. Thank you.
Mm-hmm.
This is Joy Hill. That might explain my issue that none of my patients show up under my name, because I'm listed as administrator at my building too, so they may be assigned to my administrator account and not my physician account.
I also have the same problem, because reviewing that data, this is Dr. Scher. I know that I have reviewed and spoken with families already about one completed evaluation, new evaluation in MeHealth, but it wasn't included in your data. So okay. I don't know where it's getting lost. It may have been a February as opposed to January data entry information, so it'll be in next month. I'm not sure, but I have a lot of patients that I have personally entered in that are not showing up. And I've got an administrative and a physician account as well.
And can you track on CAPC as well? I can see it on my end, but I don't see that you all have it.
What was that? What for CAP? Is that what you? Okay.
Yes, Central Arkansas Pediatric Clinic.
Okay, and again, that could be part of a couple of things, as Dr. Scher pointed out. He knows at least one of the data points might be from February data, and that's not included in the data we reviewed. Okay. Any other questions?
Hey, thanks so much. I appreciate your time and the questions, and we'll follow up with you about any other questions that'll come up as well.
Great.
Great, thanks. We got about 7 minutes left.
This is on a part that if you did there.
Kristen, go ahead and let's go ahead and finish out the reminders, and I'll present a couple of things of reliability, and then we'll switch over to the next phase of the call.
Okay, great. If you have further MeHealth questions, please contact Ed. And if you have not filled out your LS1 evaluation, please do so as soon as you can. There's the link, and I'll send it out again. LS2 is on April 13th or April 20th. It's a webinar, and again, please register for that if you have not. Our LS3 will be on August 5th at the Little Rock Embassy Suites. And our next monthly call was supposed to be on March 22nd, but that's during everyone's spring break. So we're going to move it to the following Tuesday, which is the 29th. And here's who we have who's already registered for LS2. So thank you for doing that. And if you're not on this list, if you could register for one of those 2 dates, that would be wonderful. And Dr. Kuo, do you want to go over a couple of these slides, or should we wait for the
Let's go, yeah. I'd like to, there's a few take-home points that I wanted to go through on reliability, and we can cover it more in depth in future calls. So folks, I like talking about reliable systems, and this was actually going to be a number of slides that we would have presented in the in-person learning session had we met in person. Since we didn't and didn't have the time, I'd just like to go through some of these concepts and for food for thought. So the concept of reliability is that when we're looking at a workflow and we're looking at a reliable process, what you're essentially doing is saying that you want the process to function as you intended it to in the required time that you intended it to. And the extent of failure-free operation over time, you have to think of anything you do in healthcare as a process, and you want it to be reliable so that you know it's actually going to happen. So just a very simple example is that if you give out a Vanderbilt form, you want to make sure that you actually get the results back, because that's going to help you understand what's going on with the child. Kristen, let's go ahead with the next.
I have a quick question about the reliability thing. We did notice that on the portal, there's like some forms that you can print out for the parents to sign for like authorization of release of information related to that diagnosis. Do we have to get that approved by our current clinic to be able to use these?
You mean from a MeHealth standpoint?
Yes.
Ed, can you answer that question? Are you still there?
Yeah, that is for if you are sharing the record with another physician or provider. If you look down at the left hand of a patient record, it'll show you, it'll give you the opportunity to share that record with another provider, and that's what those forms are related to. It's not for entering the patient.
So we don't have to get those signed just routinely on every patient then?
No.
Okay.
Thank you.
Great, thanks. Okay, let's go to the slide. Let's go to, see, not this slide, next slide, next slide. Okay, next slide. Okay. So when we talk about a reliable system in industry, they talk about the failure rate. And the failure rate means how often does something happen that you don't intend it to be. So if you try to draw a circle 100 times, and for some reason, 1 out of every 100 times you draw a square, for whatever reason you draw a square instead of a circle, your failure rate for drawing a circle is 1 out of 100. And we look at reliable concepts as how often you have a failure. And if it's 1 in 100, then we say that you operate at a level 2 or a 10 to the negative 2 reliability. So you need to have anywhere between about 1 out of 10 failures to be considered level 1, 1 out of 100 to be level 2, 1 out of 1,000 to have a level 3 reliable system. And you think about how many times that you prescribe something and think about whether a child actually gets that intended treatment, such as if you prescribe an antibiotic, how many kids out of 100 will actually get the full 10 days of antibiotics. I think it illustrates that in healthcare that our system isn't as reliable as we would expect. Next slide. And I think a couple of comparisons. Next slide, please. And so some comparisons are interesting in this chart. This is a fairly, we like this chart because it shows you where we are compared to a lot of other processes that are out there. So if you look at 10 to the negative 2 or a level 2 system, again, think about the number of times that you actually give out an antibiotic for an ear infection and how often the child completes that course of antibiotics, and it's probably somewhere close to the 10 to the minus 1. But if you look at other industries, cardiac surgery is about level 3, road safety and chemical industry is around level 4, blood transfusion and anesthesia is actually around level 5 safety. So their failure rates are very, very small. And you have to think about, when you give a blood transfusion, think about all the checklists and think about the protocols that you have in order to safely give a blood transfusion. And that's why the failure rate is so small. Next slide. So we want to talk, the next 3 slides, we'll talk about some of the things that you have to implement in order to get to level 1, level 2, and level 3. Level 1 is basically you get reminders and you become aware of what's going on and you work harder. Level 2, next slide, please. Next slide. Okay, let's go to level 2, when you get to a more reliable process, and again, your failure rate is about 1 in 100, is that all of a sudden you're really looking at real-time identification of failures, checklists, redundancy, and standardizations. Next slide, Kristen. And so under a standardized process, you want to look at your roles and your care of contact and use your MeHealth prompts when it's time to use a Vanderbilt screening. And so this, for example, is where you look at your workflow and think about where you could standardize the process and make sure that something happens when you expect it to do. Next slide. Additional examples include 2 people verifying that people have been notified for a follow-up visit, a diagnosis of follow-up patient conversation checklists, and daily review of no-shows and plans for follow-up. Okay. We'll go through level 3 at a different conversation. So I want to thank folks for being on call for the ADHD portion. And, well, let's go ahead and cover the PCMH part of the webinar. We've got a few things that we want to discuss.